Thank you, Bibhuti, for this opportunity. Well, I will be, already Dr. Bibhuti has described all about tPA. So I will go the opposite way, like the main indication is submacular hemorrhage. So if we see that the reasons for the submacular hemorrhage, the CNVM, PCV, and RAM, these are the main causes where the submacular hemorrhage occurs. And the PCV is the most commonly associated with a large submacular hemorrhage. And why is it so important to treat so early? Because it causes an irreversible retinal injury as early as 24 hours. So more rapidly it has been diagnosed and early intervention is done, the results are better. Because it has been seen that there is a gross deterioration of vision if it is left untreated. And definitely we need to treat the underlying cause as well. So we are not going to do the diagnosis. Treatment options are many. It's submacular hemorrhage. Sometimes it can be treated with only anti-VEGF also. Pneumatic displacement with anti-VEGF, without anti-VEGF, only the C3F8 and anti-VEGF. And tPA with anti-VEGF, that is an option. And obviously the last is subretinal tPA, intravitreal tPA and subretinal tPA. So we will go one by one case scenario. This is like, as I was mentioning, some hemorrhage might not be that large and the thickness of blood may be less than 450 microns. In those cases, actually, we can try with the anti-VEGF as well. Here in this case, you can see the presenting visual acuity was finger counting 2 feet. And with anti-VEGF loading dose, it improved to 660. Now, the next scenario is like, it's a RAM bleeding. And it was treated with pneumatic displacement RTPA. Anti-VEGF I had given because there was a macular edema. We might not give anti-VEGF for a RAM. And what happened is, following the intravitreal tPA, there was a breakthrough hemorrhage, which can happen. We need to, when we are giving RTPA either intravitreally or subretinally, we need to counsel the patient that you might have a breakthrough bleeding. This is pretty common, and the patient should be counseled before proceeding with the operation. So once this breakthrough bleeding happened, we had to take for the vitrectomy, and I will just forward it. You can see the dense hemorrhage is there. Oh, sorry. You can see the gas was still there. The tampon ad was still there. If you don't counsel the patient will go to other surgeon. But the good part is sometimes the breakthrough bleeding, especially in RAM, it's good. In a sense, you can actually take out all the blood, and the blood becomes more approachable and can be removed easily. And this patient actually did pretty good after the vitrectomy. Now we can see the retina, and that's the part. A small part is still left behind, but I think with time this goes off. So this was after the surgery, and we did a little bit of laser as well. That is the spot where the RAM bleeding happened, and the patient actually improved to 612, and a pretty happy patient. Now, this is a case where the submacular hemorrhage, you can say it's quite a large one, and seeing the OCT, it can be diagnosed as this is a case of a PCV, multiple PEDs, notched PEDs. So we planned for intravitreal tPA, pneumatic displacements with anti-VEGF, considering this as a case of a PCV. And this happened to be one of the leading cardiologist's wives, so I was a little bit apprehensive in taking this case for the subretinal tPA. So let's see with the intravitreal tPA, it's a less intervention will be required. The vision was 660, but this patient actually did pretty well. After 3 weeks, you can see the hemorrhage has subsided pretty well, and the vision has improved to 624. After 2 months, obviously we had given the loading dose of anti-VEGF following the surgery as well. And after 2 months, it improved to 6.9, and 3 months it was actually 6.6. The patient is pretty happy. So not necessarily at all the time we have to go for subretinal tPA. Intravitreal tPA does pretty well in many cases. Obviously, if it is a very large one, then we have to plan with a subretinal tPA. Like this case, there was no other option than subretinal tPA. You can see the huge hemorrhage, subretinal hemorrhage. Generally, the dictum is it's more than 4 disc diameter. We go for the subretinal tPA, but it can vary, and it's actually on the discretion of the surgeon's discretion whether they will go for an subretinal tPA or an intravitreal tPA. The good part, this patient had come pretty early. The reason I'm showing this that anything can happen after subretinal tPA, because many cases they respond pretty good, but some cases can have a lot of complications. So once we are through with the PVD and give tPA, tPA was injected with the gas tamponade. Now this patient was a outstation patient. He went back to his hometown, and then when he came almost after 3 months. So what we saw is the subretinal hemorrhage is almost subsided entirely, but he presented with an retinal detachment inferiorly. Quite a stiff one actually. This was the scenario. You can see there was no hemorrhage, almost the entire hemorrhage has gone. Except for the posterior pole, you can see a little bit of organized hemorrhage. But the retina was stiff, inferior stiff retinal detachment. Maybe the hemorrhage has subsided, but there was a huge subretinal hemorrhage. So we had to take this case and now treat it as an inferior RD, and I had to do a retinectomy. It was absolutely stiff over there. But at least this patient, when it came with a huge subretinal hemorrhage, the vision was almost, PL vision was there, perceptual light was there, but at least we could give some ambulatory vision after this settling the retina. And did a laser and did silicon oil POCL exchange. Now, coming to the last case, this was quite an old submacular hemorrhage. Patient presented pretty late. We thought, okay, let us try. Patient was given an option that generally if it is late, the results doesn't come well, but we can try. So the patient was agreed to it, and we did a vitrectomy for this patient. You can see the little bit of fresh hemorrhage, a little bit of hemorrhage is still, it is not organized, but the middle part is already organized. In this case, we obviously didn't do within first 2 weeks, which has been generally advocated that you should take as early as possible, preferably within first 2 weeks. Now, as there was a large hemorrhage and an organized one, we had given in a multiple place. Yes, if it is, yeah. Now, after this procedure, now this is 3 weeks after the PPV. I thought the macula has already will be there, but after 3 weeks after PPV, pneumatic displacement and subretinal RTPA and anti-VEGF, there was, you can see the size of the hemorrhage is reduced and the vision is improved a bit. After 6 weeks, it improved to 5 feet of vision. And after 3 months, actually, the hemorrhage totally gone. The subretinal organized hemorrhage are totally gone. But as expected, there was a macular hole formation. But this is like a late presentation of the macular hole. So there was further diminution of vision when the macular hole was formed. So we had to take this case for it's already vitrectomized eye. Now we had to treat the macular hole. Now again, you can see there is no hemorrhage. Now all the organized hemorrhage has also gone. And did an inverse peel technique. You can see the hole is quite large. So I'm almost done. So this was the result after the macular hole surgery. At least the vision, what it lost due to the macular hole formation, it went back to 660. And now you can see there is no subretinal hemorrhage. So this is also one complication of the subretinal tPA. There can be macular hole formation, breakthrough hemorrhage. Already we have shown one case. So treating the underlying pathology is very important. Whatever the cause is, if it is a RAM, you need to do the laser. PC, we need to treat with anti-VEGF injections. So this needs to be taken care. And to conclude, yes, as a general approach to submacular hemorrhage treatment, pneumatic displacement can be combined with intravitreal RTPA if there is no contraindication. But as I was discussing previously, like anti-VEGF is also, the monotherapy is also an option. So although some macular hemorrhage can be challenging to manage, reasonable visual outcome can be achieved with timely and appropriate intervention. Thank you.
May I say something?
Yeah.
Hello, Dr. Maiti. Basically, the macular hole formation happened to your case.
It was very close to.
Yes, basically in both of your cases, you have given injection within the arcade.
No, the first case.
First case I'm telling you, the distribution of hemorrhage. Another thing, one thing is size of the hemorrhage. Number 2 is duration of hemorrhage. Number 3, the distribution of hemorrhage. 3 things are important. People are talking about the size of the hemorrhage as well
and
as
thickness.
duration. And thickness, some says yes or some says no. But I should say distribution is also very important. In your first case, the ideal case for giving subretinal tPA, but not within the arcade. You could have given just beneath the inferior arcade. And second thing also, second case, you are lucky that macular hole formation not happened in your first case. But in your second case, it was very tricky situation because partially organized, partially fresh. So that in that situation, lot of addition might be there. So the tPA immediately and the force, there is sudden increase in submacular volume.
But that was the only area where the hemorrhage was there.
Submacular volume, sudden increase in submacular volume, and there was organized blood that was very there is lot of discrepancy between the adherence.
It was a mixture between organized and fresh bleeding.
Fresh hemorrhage.
No,
So
I
that
had expected this whole will happen the next post-operative day, but
yes,
fortunately it happened after 3
because
months.
of the presence of blood, it was giving some
Maybe
kind of tamponade.
it didn't
Yes.
happen.
Yes. But when you saw that some subaqueous hemorrhage is there, so you just place your soft tip cannula over the hole and try to aspirate little bit of fluid.
That
so
was
that the,
organized, no?
no, that means organize. Okay, but you are not aspirating out the tPA, but you are just closing the margin of the macro hole because you are sure, but you have seen the blowout has happened. So at that time, just you don't
With the-
wait
with
for the
the-
macro hole
with
formation in the post-op period. Just because it is my practical experience, in my one of my case, I just did only just apposition of the whole margin that will close the hole, because you are giving the gas tamponade and soft tip cannula, and you are maintaining the prone position, the hole will be closed. The blood will be vanished and hole will be closed.
The hole didn't form actually. They formed pretty late.
Pretty late, but scan line was not going through the fovea.
No, we actually did that.
If you did the six raster scan,
तो raster ही-
yes, sir, it is not that uncommon, sir. It is
The problem happens if
at
it is a
least,
large
one or two
hemorrhage, we can
cases per-
put it
if
in
you are
the
especially
side
keeping
away
the
from the
within the arcade.
fovea.
it's better to avoid go as far as from the fovea as possible.
But in cases where there is in the concentrate in the posterior pole, you can't help it. Na?
Yes, but still you have to choose the area because that's why we are choosing in the significant more than
Yeah.
4 diameter hemorrhage.